Good morning. I'd like to thank the organizers of the conference, Charles River, for their kind invitation to speak today. It's good to see everybody. Today, what I'd like to share with you is some exciting progress that Delix is making, had in developing compounds that are hopefully non-hallucinogenic. Psychoplastogens, a term I will describe in more detail during the talk, as novel therapeutics for neuropsychiatric disorders. I won't spend much time convincing you that there's a clear, unmet, and growing need for improved treatments for mental health disorders. I can throw lots of statistics at you. Just for depression, PTSD, anxiety, and substance abuse, for example, in just Europe and the US, it's estimated there are over 1 billion patients. So that's not every indication, that's not worldwide. And there's numbers I can throw at you, but leave it to Van Gogh to describe it, to picture it. Pictures with 1,000 words. There's just intense suffering out there that we can help. We really can, and that's why I'm here. I'm sure that's why most of you are, is to help these people that are suffering. The patients are really in need. And I can say without hyperbole that our collective efforts to develop novel, safe, and effective medications can directly ease this suffering, and hopefully will. Despite the unmet need, the huge unmet need, there's reason for optimism. So in 2000, there was a watershed discovery from the Yale group that the dissociative anesthetic ketamine can, under the right circumstances, have rapid and dramatic antidepressant effects in a very ill patient population, treatment-resistant depression. Don't forget, these patients are very ill and have tried many medications, and nothing has helped. And I can see on the left there, and the top on the left, I don't have a pointer, but an IV infusion of a non-anesthetic dose of ketamine, there's a brief period of disassociation, which you can see in the lower graph, which is followed with immediate relief of symptomology that is better the next day and can last for several days. Today, we now accept these findings as baseline. Yes, of course. But I should remind you that these findings were greeted with much, oh, thank you so much. I got it, yep, okay, great. So here's the brief period of disassociation and the amazing efficacy. And this was in 2000, John Crystal and Dennis Charney and the Yale group. These findings were greeted with skepticism. There was some skepticism. Not everyone accepted it. That's like, this is impossible. Come on, you gotta be kidding me. It's due to some other effect. Come on, that's not really what's going on. And there was a several-year period where people were like, not so convinced about that. It's really true. It wasn't until many years later, well, 6 years later, but that's many, Carlos Zarate at the NIH repeated and extended the findings almost exactly, perfectly. And even then, I was at Lilly trying to convince higher ups that we should get into depression. Look at these results, they're incredible. And well, it was greeted with what you might think, some questions. One thing that really helped acceptance of the findings was because it seemed like, how could ketamine be doing this? This is an NMDA antagonist, it's an anesthetic. Again, the Yale group, George Agajanian and Ron Duman, published how this could be, what the mechanism of action could be for ketamine, a reason to believe, so to speak. And essentially, they demonstrated that ketamine's inhibition of NMDA receptors triggered a cascade of events involving activation of AMPA and BDNF receptors that ultimately engage the mTOR pathway. It's hard to see on the left there, the diagram, but the mTOR pathway. And in addition, what was particularly interesting in a later publication, they showed the effects of chronic stress, chronic unpredictable stress on the prefrontal cortical neurons, layer 5 pyramidal neurons, was 3 weeks of stress was reversed by 1 dose of ketamine. Both the functional, you can see the structural, you can see the structure there, centered. There it is. Yeah. So stress decreasing, the morphological and the electrophysiological responses of the neurons, which was rescued. Both the morphological and electrophysiological responses were rescued by ketamine. Fantastic. Now, since that time, it has been shown that, like ketamine, there are similar dramatic, rapid onset antidepressant effects reported for the classic serotonergic psychedelics and entactogens. And there are some of these are exciting clinical results are listed here for different compounds. You can see a commonality of treatment-resistant depression, but also there's alcohol use disorder, anorexia, cancer-related distress, anxiety, PTSD, and even opiate use disorder. Now, I've lumped a group of compounds there together as hallucinogens, and I'm not, but they're hallucinogenic in different ways. So I'm not going to get into the debate of what's a hallucinogen and what's not a hallucinogen. That's another day, another time. We could spend 10 hours debating it and not get to the answer. However, they all produce profound sensory and cognitive distortions, and I'll discuss a little bit more, potentially better way to talk about them. But suffice it to say, these compounds, which were pariahs in the medical community, are having these very impressive clinical effects for very disparate patient populations. Don't forget the importance of that. We've been talking most about depression, but there are effects in many different patient populations. Now, in 2018, David Olson's group at UC Davis reported that, like ketamine, serotonergic psychedelics are capable of robustly increasing neuritogenesis and spinogenesis, both in vitro and in vivo. And pictured here are changes in neuronal structure accompanied by increased synapse number and function as measured by fluorescence microscopy and electrophysiology. Here we see representative tracings of cultured cortical neurons. You can see vehicle in the center there, and then afterwards being treated with either DMT or LSD. Oh, and DMT, I just read a publication this morning. There's a new publication on DMT and major depressive disorder. Preliminary results, mostly a safety study, but very good efficacy within 1 day in major depressive disorder. And then you can see actual neurons there with the sprouting new spines, synaptogenesis and neuritogenesis. This response can be quantified through Scholl analysis. You can see on the left there, analysis of the number of crossings. So the increased number of spines and neurites will, you can quantify this increase, and you can see LSD, DMT, and DOI produce significant and big changes in the number of crossing in this Scholl analysis. Now, comparable effects are produced by compounds like tryptamines, like DMT and psilocin, amphetamines like DOI and MDA, and ergolines like LSD. So different structural classes are all producing the same effect, as is ketamine. A very important clue for their therapeutic activity. So what is the mechanism of this neuroplasticity? We know that for ketamine, it seems to involve the mTOR pathway, a cascade of events, and likely it involves the mTOR, BDNF and mTOR pathway for the serotonergic psychedelics as well. And this was an effect shown on in vitro findings of the cortical neurons, cultured cortical neurons. And you can see here on the right, an inhibitor of mTOR, rapamycin, clearly blocks the neuroplastic effects, the number of crossings I just showed you for both for DMT, DOI, and LSD. And a TrkB antagonist and a 12 does the same, blocks the effects very clearly of all three compounds. And for these compounds, catanserin, which is preferring a 5-HT2A preferring, but also it's 2C and a few other receptors, catanserin will completely block these effects as well. So it's very likely to be similar downstream endpoint with a likely different beginning. So ketamine clearly hits the NMDA receptor, which produces a burst of glutamate, which hits the AMPA receptor. This is activation of the 2A receptor, which then leads to TrkB and mTOR. So a common downstream pathway producing the neuroplasticity seems likely. And it's important to note that catanserin also blocks these same changes induced by psilocin, noribogeine, and MDMA. So a common underlying effect for a number of hallucinogens. Now, do these neuroplastic effects happen in vivo? You know, what I just showed you was in vitro. That's very nice in a dish, but does it happen in the brain? And these are ex vivo studies where the animal is treated with 10 milligrams per kilogram of DMT, and then 24 hours later, slices of the brain were taken out. And then on the left, you can see, again, the morphological changes that can be quantified below that. There is increased number of apical dendrites. And then there are functional changes as well, as is measured with electrophysiology. Whole cell voltage clamp recordings of layer 5 pyramidal neurons, traces of which are seen in the middle there. And on the right, you can see significant changes in both postsynaptic current and frequency and amplitude. Now, I know those graphs, the bars don't look very different. And I'm an electrophysiologist, and it's very frustrating to show an audience little changes like that. But those are big changes. That ain't easy to happen. Those are significant changes. So these compounds are in vitro having effect. They're getting it in vivo. They're clearly changing the morphology, and these changes in morphology have a functional effect. And here's a term I want you to consider, or we think is useful, but it's up to the field to decide. A new term called psychoplastogen. Our David Olson coined in one of his papers. It's taken from the Greek roots of psych, plast, and gen, mind, molded, and producing. But it encompasses, it avoids the hallucinogen debate. It encompasses the functional activity of the compounds, what the compounds are doing, and of different types of compounds. So the compounds are typically small molecules with a measurable change in plasticity of different types, which I've showed you. Fast acting that occurs, very quickly after administration, 24 to 74 hours. And these are long-lasting changes that outlast the removal of the drug and producing therapeutic effects that can be seen in that same time course. And under psychoplastogens, this is a more neutral general term. So you can group the psychedelics, the serotonergic psychedelics in there. And we all know the serotonergic psychedelics aren't producing the same type of hallucinations. They're all different. And mescaline is more interoceptive and LSD is more exteroceptive, or however you want to classify them. They're all different. But this term avoids all that. And ketamine is not really a hallucinogen. It's dissociative. And even scopolamine is a psychoplastogen, produces these rapid effects, this neuroplasticity, and has effects in people, antidepressant effects. Anyway, psychoplastogen just may be an easier way to talk about them instead of always having to duck the conversation of, well, that's not a hallucinogen. Anyway, something to think about. So this is a wonderful opportunity. I mean, this is a game changer for people and easing suffering and a great thing to explore, and that's wonderful. But however, there are probably some limitations as to what patients can and can't take hallucinogenic compounds. One is that, and these people are typically screened from the current clinical trials. If you have a family or personal history of psychosis, it's probably not a good idea. It probably would be contraindicated. So that immediately eliminates people suffering from bipolar, schizophrenia. Now, whether or not anyone will ever, I'm sure some patient will take it sometime, but it's probably not the best patient population to go into. Similarly, patients with dementia might have difficulty because establishing the rapport that seems to be needed with the therapist to go through the long-term administration. Who knows how someone with dementia will respond. Imagine giving an Alzheimer's patient LSD. I mean, that just does not sound like a good idea. So there'll be some patients who would not be well served by hallucinogens. And there are safety risks. Hallucinogens are serotonin 2B agonists. That's not good for cardiovalvulopathy. I mean, that's what did in fen-phen. And if you hit the 2B receptor too strong, too long in the heart, you will have trouble. Now, intermittent dosing could be the way to go forward, and I hope it is, but it's something we will need to establish the dose frequency that is safe, because some dose frequency would probably not be safe, and the FDA is well aware of that. So many patients can't take psychedelics. Many patients will not take psychedelics. As Daniel mentioned, his wife, it's kind of like the old, doc, I don't care what you say. I ain't taking that. You know, there's going to be a certain number of patients who feel that way for any number of reasons. And in addition, there could unfortunately be a financial barrier because you have to take a lot of time off. Maybe everyone can't take time off from work. You have to have 2 therapists, multiple sessions. Insurance may not pay for it. It's a whole minefield that hopefully we can work through. But initially, there's going to be people who just can't afford to do that, either money-wise or taking time off from work. And then there's also the patient vulnerability issue. Some patients will feel too vulnerable for physical or other reasons in this state. So those are some of the limitations. How can we get around that? One is produce compounds that are not hallucinogenic, but still have the efficacy. A tall order, but a possibility. And so what we took, David Olson and now our company we've taken the structure of the hallucinogens, started out with the compounds that are having these profound effects that we all agree on. And it's wonderful to work backwards from a strong clinical effect. I spent many years at Lilly from the bottom up designing a compound that eventually you get into people to find out it doesn't do jack. But we're starting from a point where we know these compounds have profound effects in people. So working backward from there is a comforting and hopefully a better route to success. So and there's different, these compounds all have different structural classes. They're the amphetamine-like compounds, MDMA and DOI, ergolines like LSD, tryptamines like DMT and psilocin, and ibogaine is just a huge compound. So the idea is to start from these starting structures and modify them and see if what we can do. So if the goal is to reduce the hallucinogenic component, because that may limit the number of patients, how do you model that preclinically? One almost embarrassingly simple way is mouse head twitch. A very simple response, easily quantified, which makes it good for high throughput screening. There's high inter-observer concordance, low variability. Within subject, it's easily quantifiable and it seems to be accurate. And this, in the middle there, you can see a study by Halberstadt published this incredible correlation. I mean, I've been doing science a long time and I never had a 0.9 correlation. That's pretty good. And that's a correlation between the human dose and the head twitch response, the potency, the log of the dose and the potency in producing head twitch, not the number of head twitches it produces, which is a very important difference that some people forget. For example, LSD very potently produces head twitch, but fewer than, for example, DOI produces a massive head twitch response. Anyway, some of the subtleties of the assay, but it is a useful assay as a place to start. So here's here's what published results from Cameron et al. In Nature. We see the effects of some SAR, starting out with the hallucinogen 5-methoxy-DMT. You can see there at the top. Produces a large number of head twitches there. Make one structural change, just close that ring there on the right around the nitrogen, and you produce a compound that has much lower efficacy at producing head twitches. And then if you just make another relatively small structural change, shift the methoxy group around the carbon to a different carbon in that ring, and you produce a compound that produces virtually no vehicle levels of head twitches. So it is possible to achieve this with relatively modest, well, the chemists would shoot me for saying that, but it takes a lot of compounds to get to these final ones. But it's possible to modify the structures of the compounds. And let me show you an example of another. So it's not just for that one substructure, the ibogaine substructure. If you take the 5-methoxy-DMT structure and then shift that methoxy group around the carbon and put a little bit extra shrubbery up on the nitrogen, and you produce a compound that does not produce head twitches. Well, that's great. That's all well and good, but do you keep the efficacy is what is very important to know about. Before I show you that, let me just show you that this is not just one-off. Those two compounds were sort of the starting points. Our chemists, dynamite chemists, I got to tell you, they're probably not, hopefully they are listening to this. Guys, you are the best. No, they're really good. So we've produced, hundreds of compounds where this is the case. You can maintain the neurite outgrowth response, but decrease the head shake response. And as an extra, to me, very encouraging result, and it actually speaks volumes, not only are they not producing head shakes, they will block the production of head shakes by other hallucinogens. So they're hitting the target. It's not like they're not hitting near the receptor, but they're interacting differently with the receptor or with different receptors. And you can see on the right there, a Delix compound blocking the effects that does not produce hallucination, does not produce head twitches, Freudian slip, on its own, but will block the effects of LSD. Very, very important finding in my mind. And are there other ways to predict whether or not a compound will be hallucinogenic in people? Of course, we won't know if they're really hallucinogenic in people. We were talking about this earlier, until you get into people. And there's a whole host of questions that need to be answered and difficulties with that. But, that will be the ultimate answer. And we're getting close to that, hopefully. We'll be filing regulatory documents at the end of this year, hopefully be in the clinic very soon at the beginning of next year. Anyway, we've looked at this from a number of ways. And frankly, Charles River, I'm all ears if you can think of other assays to look at. One assay we looked at here was CFOS activation, whole brain CFOS activation, where we administered 5-methoxy-DMT, and then 24 hours later, sliced up the brain. And as you can imagine, there are multiple differences between them. And administered two different Delix compounds that we believe that do not produce head twitches. And you can see there's just a quantitative and qualitative difference in the activation of various areas, including the somatosensory cortex is one of the biggest, which anyway has some face validity for whether or not it could be involved in the head twitch response. But they're activating different circuits in the brain is the bottom line here. And we have not published this yet, and there are differences in other brain areas. It looks like it's maintaining the CFOS activation of the prefrontal cortex, for example. And that's kind of the bottom line of what we think, that the hallucinogenic and the efficacy effects are two different circuits in the brain. And that and that's the theoretical underpinning for why we think it's possible to keep the efficacy and lose the hallucinations. Again, readily admit that won't be known if these compounds are hallucinogenic in people, and then we'll also know, do you need the hallucinogenic experience for the efficacy? Another open debate, open to that question, of course. We'll see, we'll find out. We think there's a reasonable hypothesis to test, but who knows? Oh, so the other important aspect of these compounds is they do not have 2B agonism. That was the very important thing that the chemists worked in. So that makes them more safe right from the beginning. They hopefully won't have hallucinations, we'll find out, but they don't have 2B agonist activity, so they will not have the danger of the cardiovalvulopathy, nor do they produce psychostimulant-like activity like MDMA would in an open field test, which you can see there on the left. So wonderful. In animals, at least, we think there's lower hallucinogenic potential. They're safer, but did we maintain the efficacy? Which wouldn't do much good if we didn't. And yes, indeed, these compounds, as you can see here in the forced swim test, which you just heard elegant description of in the previous talk previous to mine, you can see that 24 hours after an administration of the compound, which is Delix 1 or 7 here, and ketamine is in there as a control. 24 hours after the administration, compound's long gone. There's no compound on board. You'll see significant effects in the forced swim test. And then, which lasts 7 days later, if you test them again, the effect is still there with ketamine and with these compounds. So we're very hopeful that it has maintained the efficacy, at least in this antidepressant model of antidepressant activity. We've looked at some other tests. Again, that was unpublished data. This is unpublished data. We looked at someone asked, are there other models of depression? And there certainly are. Sorry, I shouldn't say models of depression. There are models of antidepressant activity, which is an important distinction. And so we've looked at chronic social defeat and where an animal is defeated by a larger, meaner mouse and for a week or so. And there's ways to measure there are a number of effects that result from that. It's more of a psychosocial stress model, well known in the literature. But we showed that ketamine, psilocybin, and our two compounds all exhibited profound reversal of this within 24 hours after a single dose. Similarly, in another model, the chronic INF-alpha administration, which has some good face validity because patients receiving this often, depression can often be a problem for people receiving this administration, this compound administered. 1 and 7 also exhibit a similar efficacy to ketamine and much better than an SSRI. So we're very hopeful that we have maintained the efficacy, at least in these models of depression. Now, one thing, we've been having lots of great discussion around depression, very important, but what I want to remind everyone is that the extraordinary potential for these compounds in multiple indications. We're focusing on depression now, and that makes sense given ketamine's effects, or can this have this good? But there are many, many anecdotal and now clinically demonstrated effects of psychedelics in multiple indications. And one of them coming up is substance use disorders. So I came from NIDA where I was leading the group to try to help come up with new therapeutics for substance use disorder, a big impetus from the opioid crisis, and we were working on that. And there are some interesting things coming, hopefully. So we can't forget the potential, the number of people that are suffering from substance use disorders is huge, and they are essentially the pariahs of our modern society. We treat them with disdain, like it's your own damn fault, snap out of it. It's disgusting, and in 50 years they'll look back at us and wonder how could we have treated people like that with a disorder. And one thing, and there's a huge stigma associated with it, and one thing I think a new treatment will help address the stigma is that we develop treatments to help people with substance use disorder. So we went through the same thing with depression. Depression used to be snap out of it, a moral failing, snap out of it, what's wrong with you? Even when we took fluoxetine to certain other countries, the country said, essentially, I'm paraphrasing, of course, that's very nice, but we don't have depression in our country. And we're like, oh, okay. But that was the stigma around depression. It wasn't that long ago. And a new medication can turn that on its head. You see a loved one take a medicine, they get better, and maybe it was a disease. It wasn't their fault after all. Anyway, I have the same hope for substance use disorder. And the psychedelics, the hallucinogens, the psychoplastogens, if you want to call them, have potential there as well. And this is a published paper from our scientific founder, David Olson, the compound TBG, which is one I showed you earlier. This is work done by Jamie Peters at Colorado. It was a model of binge drinking behavior, established binge drinking in the animals. You dose the compound, wait 3 hours, and you see an immediate decrease in alcohol consumption and not water consumption. So it echoes what Daniel said earlier this morning, just anecdotally, that there are effects on the effects of alcohol. So there's great promise there, and I don't want us to lose sight of that. Similarly, that same compound Jamie Peters looked at in a model of taking, seeking, and relapse behaviors from heroin. And what we see here is the animals go through a period of self-administration where they can press a lever. One lever is vehicle, one lever is heroin. And if a cue comes on, indicate that, okay, well, if you press the heroin lever, you'll get heroin now. So they associate that cue, and then they go through a period of extinction training where the levers don't do anything. They get very, well, I shouldn't say they get frustrated. That's being anthropomorphic, but they learn to stop pressing. But then when you put the cue back on, which is analogous to what people in rehab are going through, they get clean and they go back out and they go back to the same environment with those cues. There can be multiple different types of cues, and they start taking again. And the rats do the same thing. So if you administer TBG at any point in that process, one time, you'll get a big decrease in the cue reinstatement effect. So if you administer it during the self-administration and then test them later on during the cue reinstatement, you'll get lower response to the cue. If you administer it during extinction training, days, weeks before you're testing, you'll get a lower response to the cue reinstatement. But if you administer it before the cue reinstatement, you get almost no cue reinstatement. So very encouraging, very suggestive, encouraging that this could have powerful effects for opiate use disorder and multiple. This whole approach, psychedelics, whether they're hallucinogenic or not, and there are studies going on with ketamine and psilocybin in these disorders. Wonderful, wonderful promise. So just as a review, how do we think our psychoplastogens, as we like to call them, work? One is, stress produces, we know, produces profound effects on healthy neurons, and you get an atrophied neuron with chronic stress. And this is well documented in animals, and it's well known, especially the prefrontal cortex. There's degeneration of neurons in many disorders. Depression, actually in bipolar, some of the most repeatable data for a decrease in prefrontal cortex cells morphology in a number of disorders. We administer the psychoplastogen, whether it be a hallucinogen or non-hallucinogen or any of the, again, ketamine, then you essentially restore the function of those neurons. You're not just dramatically changing willy-nilly. What you seem to be doing is re-engaging the synapses that were depressed by the stress or whatever. It's not exactly healing the brain, but it's one step closer to healing the brain. It's one step closer to a real treatment, a cure. It's not a cure, but it's a step in that direction. And I find that very, very exciting. And so the way we think of it is, this is fair or not, we think of these as third generation. First generation are the classic psychedelics, wonderful. The second generation are the ones, reformulations, which we heard from Daniel. There's lots of ways to go about that. And we think of these as third generation, starting with compounds and engineering them in different ways. Now, we hope they all work. There's enough suffering to go around for, we hope all these compounds work. And then eventually there's gonna be a lot of, let's say our compounds end up being non-hallucinogenic and efficacious, needs to be proven. But even if they are, that doesn't mean, no, we're not gonna need these psychedelics at all. There's gonna be so many different patient populations. Different patients will respond to different medications. There's gonna be an enormous amount of clinical work to figure out what patient gets what compound at what time. And so there's room for everybody. I hope that they all work. We really do. We're not out there saying, don't use those. Well, we hope that they all work. There's enough suffering to go around. So in summary, I think you all agree that there's a huge unmet medical need for certain neuropsychiatric disorders. I think I skipped the slide. Hang on. Well, I'll just verbalize it here. Just re-emphasize the number of disorders where there is potential here. And not only just neuropsychiatric, migraine is another one. As Daniel mentioned earlier, there are these very disparate, seemingly disparate indications that can all benefit, and including substance use disorder. And substance use disorder, a differentiation between psychiatric disorders and substance use disorders is a bit artificial in my mind. It's the same pathways, the same brain areas are involved. So anyway, there are multiple indications that we're just now learning to explore. Who knows? Maybe it'll work in TR. That's great, but its best indication will be migraine or something that it'll take a long time to figure that out. But there's so much promise. So we think that the psychedelic drugs and others achieve the efficacy through this rapid and sustained neuroplasticity. Hallucinations and safety issues will limit the number of patients that can take first and second generation psychedelics. So psychoplastogens, the general term, is an all-encompassing term for these compounds that through different mechanisms produce these rapid and sustained neuroplasticity. And our hope is that these compounds are non-hallucinogenic, which will allow more potential patients to take them, and they'll have the same efficacy. But clinical trials are never binary. It'll be interesting to figure it all out. And here, the last point here is what makes me the most excited. We can say without hyperbole, the people in this room, there are truly novel therapeutics on the horizon. And that makes me excited to my core. I spent a long time at Lilly working on psychiatric drugs. We tried our best. We pushed the needle a little bit. This is truly a potential revolution in how we treat neuropsychiatric disorders. And that's just as exciting as hell. That makes me very excited. So I'd like to conclude with that and thank you for your attention. I'll take any questions.
Great talk.
Thanks.
My question is, how long do the morphological changes last?
Yeah.
And does this track with the therapeutic response we see with ketamine?
Yes, as best we can tell, that is the case, that they last in terms of days, potentially weeks, but they start to peter out just as they do with ketamine. And there's another issue when you're taking a patient on ketamine. So he produces these neuroplastic changes, but if you throw the patient back into the same environment where all the stresses are the same, you're probably going to get that push on the neuronal atrophy again. But I think even on their own, there needs to be some type of additional dosing. Daniel told us this morning about a great way of loading with then low doses after that. So they're not a cure, not one dose, and you'll never want to. It's all over. So the neuroplastic changes occur, but they don't last forever.
Yes, you've been able to actually measure that and see.
Yes,
the
you can measure
neurons.
morphologically. You can measure that. Yes.
Okay, interesting. Thanks.
Yeah.
Good. Hello.
Oh, hey, Sanjay.
Hey, thanks again. A very, very lively and entertaining talk as well, in addition to the science. So my question is, how do the SSRIs compare to the neurodegeneration and neuroplasticity finding? Is this all through the 2A, or is this through a different pathway like beta-arrestin or?
Well, okay, so since SSRIs hit and essentially increase activity at all serotonergic receptors, the 2A could be involved in some way, but it's not the exact same. So the SSRIs seem to be better at neurogenesis, which is different from neuroplasticity. So neurogenesis was the creation of new neurons in the hippocampus, and the SSRIs tend to be pretty good at that in some of the prefrontal cortex. The neuroplasticity we're talking about is not creating new neurons, it's regenerating the spines and the neurites that have shriveled, so to speak, from the stress. So you're regrowing what was already there in many ways. And Connor Liston did a great study where he took ketamine and showed the effect that this change in neuroplasticity and a functional change. And then he was able to photo ablate just the new neurons that new neurites that were created. A little bit of magic, but it was published, so it was apparently a reasonable thing to do. And it ablated the functional changes. It blocked the antidepressant effects. So it was directly showing that it's these new neurites that are regrown or grown is harder to say that account for these efficacy effects.
This is non-clinical data, right?
Yes, that's non-clinical data.
Translation of this biomarker into the clinic, has that been shown to correlate with efficacy in the clinic?
That's been more difficult to measure. People are looking for ways to image this, and there are active ways, and we're very interested in the same. And I'm all ears if anyone has good ideas how to image this in people to show that yes, it's new neurons are grown. There are some hints of that. It's a lot harder to quantify as you can imagine, but there are efforts going on in that way. And speaking of biomarkers, one thing will be important for our group is when we get into people and we administer the compounds and hopefully show that they're not hallucinogenic, we still have to have a biomarker to show that it's getting in there, engaging the target. We can't just say, oh, see, told you, no hallucinations, and walk away. Yeah, we did it. Oh, yeah, well, how do you know that the compound's getting in there? Is that an efficacious dose? So we're working and developing. We think we have some. Well, that biomarker will be very important for us. So if hopefully the compounds are not hallucinogenic, we can say, these are clinically relevant doses that we're using.
Thanks. Do you see any application to neurodegeneration?
Heck yeah. So that was the slide I skipped over. So that's one thing that makes me very excited. And we talked about neurodegeneration, Alzheimer's, and other types of dementias. LSD may not be the best thing to give to a patient like that. But these compounds, if they are indeed non-hallucinogenic and do produce some neuroplasticity, I think that they have every chance of improving function. Now, it's not going to be a miracle cure, and I think they would work very well with the compounds that are being developed to arrest progression of the diseases, so that the A-beta and the tau compounds are essentially trying to stop the progression of the disease, which is noble and wonderful, but it's not reversing the disease. You'll essentially, if it works, you'll put some in a suspended period of low dementia. My hope is that these compounds will work well together with those compounds to start to recover some of the function that was lost. That makes me really excited. And I hope that's the case, but we'll find out.
Thank you.
Thank you, Kurt, for the presentation. Very important, very interesting presentation. A couple methodological question. In the Scholl analysis that you showed, did you look at the total number of crossings or just the primary crossings when quantifying them?
I showed you total crossings.
Total crossings, okay.
But there are lots of ways to slice and dice that data.
Exactly.
Accepted. That was published. It didn't come from my lab. My guess is it's David Olson's lab. We could go back and relook at re-slice and dice that data in any way you want.
Yeah. Thank you. And the second question, do you think that those non-hallucinogenic compounds, are they going to be Schedule I compounds or?
Our hope is no, because if they really are not hallucinogenic, they'll essentially be like any other antidepressant. And our hope is that it's take a bottle of 30 home with you from the pharmacy, just like Prozac. That's the potential.
Sounds good. Thank you.
We'll see.
Okay.
Oh, hi.
Very nice talk. I enjoyed it very much. You touched on target engagement. I wanted to ask you if you have any thoughts on what target you're not engaging for dissociating hallucinogenic activity.
I have lots of thoughts that I'm not going to share with you. No, I've got. We have lots of hypotheses, and I can only speak in broad generalities about it. But just the circuitry, there are 2A receptors in multiple areas, and there are different. You can affect the circuitry differently with different compounds, and binding to 2A receptor, it will be likely misleading if you just go by binding to the 2A receptors and overexpression of 2A receptors in CHO cells as your guide as to what's happening in vivo at the 2A site. The world of GPR signaling is even more complicated than we thought. And And I think if we're right about what's going on there, it will be, I know this sounds crazy, but it could be a new way of mining GPCR functioning signaling to produce therapeutics. We're starting out with the 2A receptor, but it's going to be true for other receptors as well, muscarinic receptors. There's different, the GPCR world of signaling is way more complicated than we thought.
Yeah, we have some peripheral side, a lot of data, including in human translation. But in this particular case, I'm wondering if you looked at any muscarinic related. That could be.
That's so, I showed you, scopolamine is on that list of a psychoplastogen, just so it's in our minds.
Thanks for great talk. I had a question about the slide where you're showing the dosing for compound 001 and 007.
Mhm.
So you showed essentially like an order of magnitude dosing, 1 milligram per kg to 10, but
It was flat, wasn't it? Yeah.
well, it went down a little bit. So I had brought this up in the prior talk about psilocybin at 5 milligrams per kg in a human is a lot. But that's part of the promise of this, right? We don't have, it's like the same thing in cannabis. They can give people a lot more CBD than you can these other cannabinoids, right? So I was just wondering, what is the implication in your mind of that? Does that mean that 1 milligram per kg is enough? Does that mean, I'm just kind of highly interested in the
Yeah.
dosing side of
I
it.
think, yeah, a great question. I wanted the same things, but it's just too hard to go from, the animals metabolize things so differently. The PK is so different in the animals than in other species. And we don't know what the PK will be in humans. And that's going to have a profound effect. So until we had that figured out, it's hard to really make a lot of conclusions, but I've got the same thoughts in the back of my mind.
Thank you.
Thanks for a great talk. One question I have is when you look at the plasticity changes, so the spinal morphology changes in vivo, are you seeing like subtype specific effects of those changes? Is it, predominantly on in excitatory or inhibitory cells, or
Great question.
have you looked at any of
We
that yet?
haven't dug down that deep yet, but that is certainly something to pursue. We've just been looking at, the functional output of the pyramidal neurons. There's a lot more going on that we can investigate. We're happy and excited about the strength of that response, but there's a lot more to pursue scientifically beyond that.
That's super interesting. Thank you.
Thanks.